Good morning, everybody. We're just letting everybody into the room. It is 9:03, so we'll go ahead and get started. I'd like to welcome the participants to the North Carolina Rural Coalition Fighting COVID event. This coalition and partners include North Carolina Office of Rural Health, the Foundation for Health, Leadership, and Innovation, also known as the Foundation, Hometown Strong, AHEC, and the Rural Center. My name is Nick Alves. I'll be your facilitator this week, and I work with the North Carolina Office of Rural Health. We have lots of great speakers this month, and we're also expecting lots of discussion, chat, and/or questions. Some of the housekeeping items. We know some of you may have joined by phone, so if that is the case, we know that you're only hearing the audio. We will open up or allow for questions through phone only towards the end. You can unmute yourself with *6. For those on the computer, it's best to put your questions, comments, or chat in the chat box. That way we can respond quicker. We can also document your questions or your comments in the chat box. We do save those for review later. And also the meeting is being recorded. So we'll look at that, and you can also share it with your partners at a later time. This week, we're so fortunate to have Kelly Crosbie, a colleague of mine at the North Carolina Medicaid office. She is the Chief Quality Officer. She'll be talking about mental health service in North Carolina and how COVID has impacted them. We'll also hear from two other providers who I'll introduce at a later time. First, we'll hear from Kelly, and to give you some background information on her, she is the Chief Quality Officer at North Carolina Medicaid. She's responsible for overseeing all quality improvement and population health programs aimed at improving health outcomes, promoting health equity, paying for value, and addressing medical and non-medical drivers of care. From 2014 to 16, Kelly served as a Chief Operating Officer for CCNC, a statewide primary care medical home system. From 2008 to 13, Kelly worked as the North Carolina Medicaid Chief Operating Officer and as the Assistant Director overseeing behavioral health benefits. Ms. Crosbie received her master's in social work from Temple University and her bachelor's from the University of Pittsburgh. She is an appointed member of the North Carolina Institute of Medicine, the North Carolina Quality Assurance Public Sector Advisory Committee, and Equity Standards and Subcommittees, the National Collaborative for Innovation and Quality Measurements Advisory Panel, and she served on multiple technical advisory panels for CMS, CCMI, and NQF initiatives. Kelly, I'll hand the mic over to you.
Thanks a lot, Nick. Appreciate it. So hey, everyone. I know many of you, but just meeting some of you for the first time. So thank you so much for having me today. So what I brought to you today was and some of you have seen some of these slides before. Obviously, during the beginning of the public health emergency, and you'll see it in the slides, Medicaid really worked to implement a much broader telehealth benefit for both physical and behavioral health services. And at that time, too, we started to try to monitor and also evaluate the impact of care delivery, the impact to care delivery, patient outcomes, general utilization. And so today I'm going to share some of that. Some of the data that I'm going to share with you just applies to all Medicaid services broadly. Some applies specifically to behavioral health services. So I tried to pull out where we have some good behavioral health data for discussion today. And then I will tee up a little bit kind of what else we continue to look at, and would love any feedback, questions about what we are looking at, and feedback about what else you guys think that we should explore. So with all research, we're not necessarily trying to draw inferences about why in many cases or conclusions about what it necessarily means. So we try to be really circumspect because most things that you see are really multifaceted, right? There's a lot of drivers why we see things, and certain things we see don't always lead to the kind of outcomes we propose. But so a lot of what we're sharing today is really just some basic data, but where we were able to do some deeper analysis, and really smart people who know statistics and evaluation were actually able to do some evaluation where things were statistically significant or meaningful. We've shared this as well. So that was a long-winded explanation, but we're very excited about this data. And so again, try to highlight the places where we have particular data to rural impact and behavioral health impact. So here are the takeaways that we're going to talk about today. Many of them don't probably seem that astounding, but at the beginning, as I said about the public health emergency, we really said, okay, we're about to implement this benefit. What are some things we want to understand? And we actually came up with a list of, oh my heaven, I'm not exaggerating when I say 50 research questions. And believe it or not, we've been iterating through a lot of those research questions over the past year, and some we continue to iterate through. But some of the really basic things we were trying to ask, and we've asked them in a variety of ways, is who actually is using telehealth? And you'll see some of the data on that. What are the impacts and outcomes? And hold on one sec, I'm having slides. Can you all see my slides? And are we seeing that any of those things that people are afraid of? People are afraid of telehealth. They always have been, right? You know that. I'm talking to experts, right? Is it going to cost more? Are people going to get poor outcomes if they're getting services via telehealth? Is it going to result in these massive amounts of fraud, waste, and abuse and excessive billing? So some of those are really fundamental questions we wanted to press on, right? Is it effective? Who's using it? What providers are using it? What members are using it? And is it escalating costs like we think it is? And is it leading to poor health outcomes? So we're trying to press on some of those issues. So here's some of the really basic takeaways that we're going to share today. So obviously there was a very large drop in the total volume of care delivered during the first few months of the public health emergency. Obviously, you'll see that. There was a significant increase in telehealth and telephonic services, and that made up some of the gap for the loss of in-person care that we were seeing. Telemedicine use was actually very robust for behavioral health services, much more robust, you'll see, than it was for physical health and OB care. Those were kind of our two comparative groups. The rate at which we saw telehealth uptake was different. It varied by geography and other member demographics. We'll show some of that. The rate at which providers participated also varied dramatically. And our initial evidence suggests that telemedicine has replaced in-person services to a significant extent, actually. So it was a good thing. And a lot of the adverse outcomes that people fear, we didn't really see. So we'll talk about a little bit of those as well. And I'm going to try to stay within my time limit because this stuff is just darn interesting. So the first thing, this is just kind of an orienting slide. If you look at the gray line, that's our typical claims volume here at Medicaid. That's all of our services. That's our typical claims volume. So tracking back to December of 18, that's our typical line of claims. There's always a dip at the end of the year, right? So like that super, super sharp dip at the end of December, beginning January. That's terribly typical. But what you really want to focus on is that February, March, April dip. That was a very dramatic dip for us, right? And that was really the beginning of the public health emergency. And what you'll see called out in the box is actually we implemented very swiftly in March our telehealth benefits. And the yellow line is our telehealth claims adjudication, and our blue, that was our telehealth is the yellow, and the telephonic services are the blue line. So prior to that, we had very few telehealth benefits at Medicaid. We had some, you'll know, we had a couple, but not the massive amount we have today. And that yellow and blue line actually helped to push up the gray line. So the gray line is actually inclusive of the yellow and blue as well. So that was able to help boost the dramatic dip we saw there in March and April. So let's talk about ratios a little bit, and we tried to add in some of the phases of the public health emergency. So in early March, we implemented the telehealth services. I believe our actually first COVID case was logged, was it something like March 3rd in 2020? And we enacted the telehealth policies very soon thereafter. The governor issued the stay-at-home order there, you see, towards the end of March, and then it was lifted. And so during that stay-at-home period, you see a dramatic, even a higher increase. This shows percentage of claims that are attributed to telehealth and telephonic services. So you saw 7% attribution, and remember that number, 7% of overall claims. It was at its peak in the months of April. It started to wane in May, and then we're at somewhat of a steady state. Again, you see that same, a really interesting dip over the holidays. So we still see the same dip for telehealth and telephonic services during end of year, beginning of year. And at the end, you'll see a dotted line. So on every chart, mostly you'll see a dotted line. That's claims run out, and that is not in any way indicative of how that's actually going to look in about 4 weeks. In about 4 weeks, we'll probably be at around 4-ish%. We'll probably maintain around 4 to 5%, which remained fairly steady, that 4 to 5% uptake. Okay, so this is where hold on one sec, sorry. I'm having really weird issues with my screen, but you guys are seeing everything, so we're okay. So here is the comparison actually of physical health to behavioral health services. So the green line is dramatically higher. We see a lot more percentage of telehealth claims for behavioral health services versus physical health services, and that trend continues today. So much greater uptake of behavioral health services. These are our telehealth, telephonic, and in-person behavioral health volume. So gray is always our in-person. Telehealth is very high, and our telephonic, again, that remains our lowest. It's lower than in-person, but look at the volume of telehealth compared to the volume of in-person. That's a lot of claims for us. And I think it's such a marked difference. I'm trying to find the, I don't know if we hit this slide yet that shows, maybe we did, hold on one second. Yeah, I mean, look at just the percentage of claims that are physical health versus behavioral health. I mean, it's extraordinarily different, right? The uptake in behavioral health is just exponentially higher than the physical health services. Sorry. So we also broke down, again, when we talk about who's receiving services, we broke down our services by race and ethnicity. You'll see also by age. And the lines that you want to pay attention to, not that the other lines don't matter, they absolutely matter, but the yellow and the black lines are the ones that you want to pay the most attention to, only because our sample size actually in our Asian American or American Indian and our Hawaiian and Pacific Islander populations are incredibly small, but these are percentage. So it is percentage of claims for those populations that are telehealth claims, and that is telehealth and telephonic claims. So we do see still a smaller percentage, and this holds in so many cases in Medicaid. We do see just overall lower penetration of care in our Black and African American populations, in our non-Hispanic populations, than we see in our Hispanic is usually higher, and usually white and Caucasian utilization is higher. So this is higher. This is about 3 or 4% at any given time. The Caucasian to Black rates are higher for telehealth uptake. Age is really interesting, and it goes from youngest to oldest. So most telehealth utilization that we saw was in the highest was use group was our birth to 20. Next highest was 21 to 44. Next highest is 45 to 64, and then 65 plus. And this is a great example of, like, you could spend for a really long time about what that means, right? Like a really long time. So this is not diagnostic specific, it's not procedure specific, it's just purely claim volume by age group. So there's a lot of ways that you could cut and split this data and analyze it further. So yeah, can't take a lot from that. Ethnicity, again, our Hispanic uptake was higher than non-Hispanic. Again, that follows trends we typically see for any service utilization. And here are the odds. We did some odds analysis. So the odds of telehealth service utilization among beneficiaries in urban areas is 1.2 times greater than utilization odds of beneficiaries living in rural areas. That probably makes sense. So you see a later slide. So white beneficiary use is 1.2 times greater than utilization odds around our Black and African American beneficiaries. Non-Hispanic beneficiaries is 1.4 times greater than utilization odds among Hispanic beneficiaries. And beneficiaries with a chronic disease is 3 times greater than utilization odds among beneficiaries without a chronic disease. Makes me question something on one of our other slides. Okay. We got some really interesting survey data. We just have tons of survey data because our team really likes qualitative analysis. But we had this really cool opportunity. So we got surveys every week. Probably y'all participated in it. Our wonderful AHEC coaches, just wonderful. We got survey data every single week from primary care offices. Wonderful stuff. We used it every week. I didn't bring any of that. But what I did bring was some of the survey data we got from 2 behavioral health providers, which was really interesting. So they surveyed folks who just liked their virtual visit and if they would like to keep it. And so we actually saw that 59% of people said they would like to continue with their virtual therapy if they were given the option in the future. But we saw a distinct difference between Black and African American respondents. So white respondents, 73% of the time said, yes, I like this virtual visit. But Black and African American respondents only 44% of the time. Now, these are really, really small sample sizes, really small. We also talked about technical difficulties. Is it working for you? 84% of respondents had no technical difficulties. Again, one specific provider with multiple sites, but part of that you want to press on, like, where are those sites at? How easy is it to get access? And then another provider looked at self-reported outcomes. So these are patient-reported outcomes. How do you feel that you're doing? Asked in those surveys, they did not see anyone saying they had adverse outcomes or they reported any different outcomes or better outcomes if they received their care virtually versus in person. So that's just some of the really interesting qualitative data that we were able to get from behavioral health providers. Now, this is really, really interesting. So we looked at, and this is just one of the slides, we looked at utilization in rural areas and areas with broadband access. And so we looked at both primary care and behavioral health care. So rates of primary care and OB services that were telehealth decreased as the percent of counties' populations living in rural areas increased. So that makes sense, right? Less telehealth in rural areas. That's what we saw for primary care. We saw an increase in primary and OB telehealth utilization as counties had better access to broadband, right? Those things like make sense, right? Less rural you are, or more urban you are, more telehealth, more broadband, more telehealth. But this didn't hold at all in behavioral health. That trend was not the same at all. It just wasn't. Completely different. So those relationships did not hold, which we found really, really interesting. And then I just threw in some kind of access stats that we looked at. So we looked at primary care uptake, and primary care offices that had high to no utilization of telehealth, and the number of their members they were able to serve during the period of time that we were looking at. So again, most of this is quite logical, but practices who used a high percentage of telehealth were actually able to see a large volume of their panel versus those who did not use telehealth at all. So a much lower proportion of their panels during the period of observation. Again, makes total sense, but it also just points to the fact that telehealth really is a wonderful way to ensure that there is access during the public health emergency. This is then the next couple of things really were some of the questions we asked around is telehealth causing you to have more service utilization or to cost more money? So these are the next couple of slides that we looked at. So a second visit with a physician, whether in person or telehealth, was actually less likely after a telehealth visit. So we did not see a trend of once you have telehealth every week. And it's just like rife with fraud and abuse. Now, again, this does not speak at all to like why someone actually had an in-person versus a telephonic visit and what that says about the condition they're managing and if an in-person visit is more appropriate. It just totally gets at that question of, as a whole, when we look at telemedicine, do we see just overbilling? So far not. So total cost of care in the 2 weeks following a primary care visit, we didn't see a lot of difference in our non-ABD population. So that's our less severe population. That's our women and kids, right? That's the vast majority of Medicaid. So we didn't see a lot of difference in cost between an in-person visit and a telephonic or telehealth. A little bit less for telehealth and telephonic. I honestly, my notes are at the bottom if that's statistically significant or not. The total cost of care 2 weeks, 2 weeks following a primary care visit, though, for our ABD, which is our very complex population for Medicaid, that's our complex eligibility group, we did see much higher costs for those that had a telehealth visit. But again, all that does is beg the question of why. Let's dig into that, right? Let's dig in, because who knows? Who knows why? Who knows if the telehealth visit unwrapped a particular problem that the person had to come in for or had to go to the emergency department for? Like, we don't know, or yeah, I mean, so there's just a lot of reasons to unpack that. The percent who used a hospital within 2 weeks of the primary care visit. So again, we see, again, I can't tell you what this says, but the most significant one is folks who had an in-person visit in our complex group, our ABD group, they were much more likely to use a hospital within 2 weeks of an in-person primary care visit. But again, it was the person coming to a primary care visit because they are a complex person that has complex needs. They needed an in-person visit. And so the likelihood of having to go to the hospital was just higher anyway, like, to know. Again, something worth unpacking. I think these are actually my last two, and I think they're really, really, really interesting. So let me try to explain them well. So we actually looked at the probability of medication use for members who received some sort of services during a particular time period. So we said you used services, how likely was it that in the months following the service that you got or didn't get, would you get an antipsychotic medication fill, or would you get your opioid use medication filled? So overall, the first line really says you had an in-person visit, and then subsequently you got your antipsychotic filled or your opioid use disorder medication filled. So telehealth actually fared a little bit better. If you had a telehealth visit, the likelihood of you filling your antipsychotic or your opioid use disorder medication, and these are actually statistically significant differences. So overall, if you had a visit in person or a telehealth visit, it was better. The likelihood of you filling your medication was just better than if you had no visit at all. So that's the last line, no visit at all. But we actually saw higher fills for both categories after a telehealth visit as opposed to an in-person visit. And this next slide is just very similar. We just did another type of analysis on the data. So we just had higher rates of people refilling their antipsychotic medication compared to beneficiaries that didn't receive services. So again, this was just another analysis, but the same question. So telehealth only beneficiaries had a 6.8% higher probability of refilling their antipsychotic. In-person folks had a 3.9 higher percent probability. So that's really interesting. So that's definitely a statistically significant difference. I have no idea what that means, right? Like, again, these are wonderful things, and you could read so many things in them. And the same held for the opioid use disorder medications. So if someone had no visit, much lower chance of filling their meds. If they had it in person, it was about a 15% probability that they would get a fill. But if they had a telehealth visit, it was even higher. It was 17.3%. And so just a couple of things that are in the works, and then would love any feedback. We are fielding our consumer survey. It's our consumer survey that we do every single year. And this year we have actually, and it's a national survey, everyone knows it, it's the NCQA survey. It's members' rating of their healthcare and their access to care and the professionals that serve them, their health plan. We are actually, we did two things this year. We added telehealth questions to it. So we added, if you had a visit, how did you like the visit? How was your access to the visit? So we actually added telehealth questions to this national survey, or it's a statewide survey, but CAPS is national. And we also oversampled this year. I believe we are the first state in the nation that is using an oversampling approach, so we can stratify our consumer surveys by race and ethnicity. So we've added telehealth questions, and we've oversampled to be able to sort by race and ethnicity. And one of the things we're looking at right now, which is really interesting, and how did telehealth use compare to rates of COVID-19 within a practices population? Don't read into this, but it was just really fascinating. The early results show that practices that used higher rates of telehealth had lower rates of positive COVID-19 within the practice. Again, I didn't put that slide in there because I think that's folks are still looking at that one because I think that's really interesting. I think we're still trying to ask the question, is it as effective? We have some other slides, particular to behavioral health, actually, that are really trying to look at adverse outcomes of beneficiaries, and it's very complicated. And so those slides, we would say in general, with the indicators we're looking at, we are saying for behavioral health and substance use populations in general, we think there were far less adverse outcomes for beneficiaries during the public health emergency if they used telehealth services, but that's still undergoing some analysis. We are just getting our quality measures for last year. And, this is where everyone thought we would have dramatic decrease in our quality measures. So that's everything from kids getting immunizations and wall visits to kids on ADHD meds, where they're getting follow-up, to kids on antipsychotics, where they also engaged in psychosocial treatment, people that were hospitalized or went to the emergency department for mental health reasons? Did they have adequate follow-up visits in the community with the specialty provider? So those very, for those of you that are in quality, those are those are very standard national metrics. In general, our health measures trend well. We actually were astonished by how well people did with well visits and immunizations in things that you could not do via telehealth, which is really interesting. But other things that telehealth counted, our metrics are good. But some of our behavioral health measures, in particular, our follow-up after hospitalization, even though hospitalizations were down, our follow-up rates did worse last year. So we're trying to look at some of our, which is a shame, right? And those are metrics where telehealth visit would actually count as a follow-up. So it's not like that visit was discounted. We did worse actually last year, but we're still analyzing those right now. But I think the question for y'all is what else should we look at? And I kind of breezed through that. We can share the slides, and I think every single thing you probably want to unpack a little bit more, quite frankly. But welcome any feedback or questions or comments. And also I know there's another speaker, so I don't want to hog the time.
Thank you, Kelly. That was fantastic information. And I know our office, the Office of Rural Health, has seen those surveys because we've asked our providers to complete the surveys because we have always been a big proponent of telehealth. Glenn just put a sort of a comment there. Glenn from our office, he said, would like to see the impact on children with depression getting treatment. And so that's sort of a subset of your data. Before we move on to the next speaker, I just want to point out some of the highlights of your telehealth analysis, and showing the behavioral health is so much higher than the physical health, as much as 30% for the behavioral health versus 10%. And so at our office, because of our providers being rural, oftentimes the option is nothing at all and continue to get worse medically and then go to the hospital and get the physical visit. But at that point, the patient is very sick, or getting telehealth. So we are definitely of the persuasion that we're encouraging our providers to complete telehealth. And the challenge really is the providers. The technology is there. The regulations have been freed and opened up from Medicaid and CMS as well. So it's there. I think for us, we're just trying to look for providers. And I also want to point out that the surveys that you all do reporting patient satisfaction and patient outcomes, and the fact that you said there was no adverse outcomes. I mean, if anything, telehealth would find somebody that if they're going to have an adverse outcome and find it earlier. So just wanted to point that out. There's a couple more comments in the chat. And Robin Huffman from North Carolina Psychiatric Association asked, is there a way to look at future disruption of therapeutic relationships and patient outcomes by corporate telehealth providing episodic care? Not sure exactly what she means by corporate telehealth.
Yeah, and I think, yes, I think we absolutely can. I'm trying to think about if the bucket of the big lake of data that we're looking at right now has that, but it can, because that one primary care statistic that I showed you, that one in particular was looking at that is the place you get primary care in person versus that is the place you got telehealth in person. But I think that's a great question, Robin. That's come up a lot. The question is, if people are getting telehealth, are they getting it with their medical home or their typical behavioral health provider, their substance use provider that they're typically engaged with, or are they getting it somewhere else? I think that's something really interesting to look at, Robin, and I think we can.
Yeah, another question is, this is from Tanya Majet, I'm not sure which organization. Are the telephonic behavioral health claims having a significant lower reimbursement rate compared to telehealth?
Oh,
and I believe she's referring to audio only there.
Yes, telephonic visits are lower reimbursed, and nobody likes that.
So the answer is yes, they're low.
I do not know if I have much sway around that, if I'm honest, but because that's been debated far and wide.
Yeah, well, I know at our office.
Yeah, I think,
like
yeah, like culturally, I'm just going to be honest, like culturally, knowing where we've been, and others on the fin know where we've kind of been probably 5 years ago versus today, like really just that discomfort with the adequacy of a telehealth visit. To see us culturally like come here is extraordinary, truthfully. I think telehealth is still a different frontier. There are folks that just don't think that is as inadequate as an intervention. So.
Yeah, and I'm of the impression it's better than not calling at all.
Oh, totally. And I think people agree, right? They're saying, yes, agreed. Therefore, we're going to reimburse it, but just not as much as if you can see a person. So, but I think some of that too, and I don't mean to be flippant about it. I think the more that there are studies about the efficacy of telehealth services, the better for agencies like Medicaid, right? Where we have the data, we can take it to our clinical team and say, hey, it's just as good. So let's just cover it at parity. So, yeah.
Yeah. And I see one comment from somebody saying that some patients don't have broadband and they still have to drive to the clinic to use their iPad in the parking lot.
Totally. Absolutely. One of the really, and we truly appreciate that, and I should have called this out, so apologies to the rural health team. Everything that we did data-wise, so much of it was with coordination with the Office of Rural Health, because like it's great if Medicaid can cover something, it's great. But it's if people don't have whatever, if they don't have equipment, if they don't have broadband access, then thanks for covering something, Medicaid. So like that was a really great example, I think, of partnership between like folks who have complementary functions, right? So I really appreciate the rural health team for helping us with everything from understanding access, but also championing all the programs for people to get broadband access and equipment. And our practice is to get equipment too. I mean, yeah, kudos to you guys.
Yeah. Thank you. We appreciate your partnership, and we've leaned heavily on the Department of Information Technology and the Broadband Infrastructure Office.
Yeah.
Before we move on to the next speaker, I just want to end on a good comment. Robin Huffman said that the psychiatric physicians are shocked at how well patients and families are adapting to telehealth, even for the tough cases. Most prefer in-person care, and obviously that's better, but are grateful to be able to deliver good care by phone or video. So that's someone who has a pulse on the psychiatric care within North Carolina.
That's cool, Robin. Yeah.
Great. Well, thank you, Kelly. This was great. And the slides and the presentation is shared on the FHLI website. And I'm sure if we have more questions or comments, we'll send them to you, Kelly, or we may ask you to come back.
Great. Thank you all for having me. Appreciate it.
So next up, David Peterson will be talking. He is a clinical social worker in Wilson, North Carolina. He graduated with honors from the Brody School of Medicine at ECU in 2013. He has more than 8 years of diverse experiences as a clinical social worker, and he affiliates with no hospital, cooperates with many doctors in the medical group Carolina Family Health Medical Centers. And I will pass it over to David on that note.
Hello, everyone. Just a clarification. I didn't graduate from the School of Brody Medicine. I graduated from ECU School of Social Work. So I apologize for the misinformation. My presentation isn't going to be as thorough and as research-based as Ms. Kelly. I mean, she did a fantastic job. I guess I'm going to be a little bit biased because it's going based off of my experience and observation of what's going on in the area of Eastern North Carolina and the research that I've done as far as what's going on in other states. As far as care goes, it's been interesting. Right now, we're not, actually, let me just apologize again because I might be bouncing from topic to topic because I have a lot of stuff that's going on in my head. Right now, getting updates from my wife about things that are supposedly taking place later on today regarding COVID, which is just, I mean, it's a stressful time of the, just say stressful time in general. But in regards to care and treatment, we as a corporation do offer telehealth, but we're doing primary face-to-face visits and trying to be as cautious and careful as can be, face mask and social distancing and what have you. We hold the COVID vaccine clinic throughout the week. And I apologize, I don't really have much data to share in regards to, how many individuals we see on a regular basis. I would say that our numbers overall have picked up. We do provide substance use care under an MAT model, medication assisted treatment model, at 2 of our clinics. The one clinic that we've been doing it at for the longest, which is in Tarboro, has had a pretty drastic decline. We started out where we hold it 2 days out of the week. And initially we were seeing anywhere from 20 to 25 people each day of the week that we had provided care. And that number has decreased pretty significantly. Went from, as I said, 20, 25 to anywhere from 10 to 12 on a schedule. That number is slowly starting to increase. Again, we really don't know what the cause of that would be as far as the decline. The substance use population has interesting behaviors. I mean, there's really no clear way to pinpoint a trend. I think when we kind of have an idea of it, it throws us through a loophole and catches us on our feet. There is definitely an increase in fentanyl use. I've heard that carfentanil is on the rise, as well as cocaine and meth. And it actually brings me to an interesting comment that somebody had made in a webinar that I had sat in regards to the use of alcohol, cocaine and meth. Those are actually on a rise. Those are increasing steadily and surely. But right now the focus is on opiates. And from the discussions that I've had in regards to grant funding and whatnot, it's solely targeted on opiates. So if we're not careful in our approach to addressing the problem, then we're going to get blindsided by the rise of other substances that that have been in place and have existed for a long time. I think the approach should be community care, community wellness, and not just treating a symptom. I think we have to go to the core of it. And I think that deals with a lot of education, a lot of nurturing of families and smaller communities. I think we've taken our eyes off of that area, and I also I'm reassured that there is attention that is focused on trauma, because I'm a big supporter on trauma treatment. I think that is one of the main areas that is causing a lot of the issues that we face now. Stress, toxic stress, post-traumatic stress, whatever stress that we face on a regular basis. We just do what we can to cope, to survive, to just make it to another day. As I was talking to Carla in our conversation before this meeting, I think a lot of attention is given on what we do, but not on ourselves in itself, and that we lack self-awareness. We're just so ready to go and take care of other people, but we neglect ourselves and the care that we so richly deserve and require in order to be healthy. One of the things that I'd ask Carla was, when was the last time that you just sat and thought about your thoughts, did some mentalizing, did some meditation, just some conscious breathing, and having that communication, that dialogue with self, just to check in and see how you're doing, where you're at, where's your mind, where's your heart, and at times where's your body, because I don't know if I'm coming or going these days, because I'm having to cover 3 clinics, and that brings me to my other comment or situation.
David.
Is that weird? Yeah.
Hey, this is Nick. Just wanted to let you know we're trying to wrap your speech up by 9:45.
Okay.
So I just wanted to give you a heads up rather than cutting you off. So you just still have about 2 or 3 more minutes.
Okay, great. One of the main problems that I've seen is lack of workforce. We're down 2 clinicians, and we're trying to hire that. We posted our positions on the web, and we've maybe gotten 2 or 3. When people are asking questions about our positions, we say that we're in-house, and people are like, no, I don't want to do that. I'm working from home. And so when you have those clinics that want to have a face in a certain location, there's a lot of shift, a lot of trend of people that want to say, no, I'd much rather work remotely. When we're trying to create some initiatives to help the need in the community and be in the presence of the community, that's been really, really tough, because there's just a big shift towards the telehealth. I don't want to talk negatively about it. I agree, but I think that there's a big, there's something to be said when you are in the presence of somebody, really reaching them and connecting with them in person, as opposed to from distance. And right now we have a position, and I'm not trying to advertise our need for clinicians, but it's just looking at the hurdles and obstacles that we face. Right now we have a position, we're trying to create a model where we're trying to hire for a peer support specialist, and we haven't really had anybody to fill or to apply for that position that would meet the criteria that what we're looking for. So I mean, that's what we do. I mean, I apologize for going all over the place in my my spiel, but I guess I'll leave the last minute for any questions that anybody has.
David, no, this is exactly what we needed, because Kelly presented a lot of data and showed some of the trends, and you have feet on the ground, and it sounds like you've been running around just to manage the clinics, and so right now we don't have any questions. We do have a comment from somebody. Many clinics we work with are reporting lack of workforce as well. It's troubling as the need increases, and I pointed out to Kelly that even for those that are seeking telehealth positions, we advertise for our hospitals and our clinics, and even those people are lacking if we tell them it's going to be 100% telehealth. And I'll also point out, at the Office of Rural Health, we track the health professional shortage areas, and 94 out of the 100 counties are health professional shortages counties. Pretty sure Wilson is one of them, because a lot of the psychiatrists are located in Raleigh, Durham, and Charlotte, and we have a need there, and the need is met, it maybe even exceeded. But in the rural communities and even some of the semi-rural, there's not enough psychiatrists and therapists there. And so I also do agree with you, in person is much better than telehealth, and if we have the ability to do that with patients and providers, that's the preferred method. But I think it's just not there. The number of providers are not there, and the clinics aren't as well.
And that's one of the things that I wanted to mention too, is that there is a talk about the pandemic, but I mean, there's a shortage. I mean, there's a huge drought of professionals, licensed clinicians, physicians, to fill the need of the people in the community that are hurting, that are in dire need of help. And I think that also is something that we're overlooking.
Definitely. Thank you for your experience, David. If you have time, please stay on, because there may be more questions and comments.
Yeah, I'll be on. Thank you for the time and opportunity.
We'll move on to our last speaker here, Marie Nemerov Gannon. Quick introduction on her. She has been working in substance use disorders field since 2013, and worked in a variety of treatment modalities, including integrated care, inpatient, outpatient, and wilderness therapy. She's a co-founder and former director of Project CARA, a perinatal substance use disorder program at MAHEC, Mountain Area AHEC OBGYN. Marie now works in private practice, specializing in reproductive mental health issues, providing clinical supervision to individuals working on substance use credential. Marie, I'll pass it over to you on that note.
Thanks, Nick. And thank you. You made me about 10 years younger. I've been working in the substance use field since 2003. And that's where I want to start. I don't work with any substance use clients directly anymore, but I do provide a lot of supervision to people working on their LCAS, or now their CADC, the Certified Alcohol and Drug Counselor credential, through a contract I have with 2 of the methadone clinics here in the West that provide, I should say 2 of the OTPs, that provide methadone and buprenorphine services to about 8 of our far west counties. And some things that we have learned from them is, because of the public health crisis and some emergency waivers that were put in place in March of 2020, they were able to increase the speed at which clients could like quote unquote earn their take homes, right? So they could stop paying attention to marijuana use, and they didn't have to meet specific guidelines for the time and treatment to be able to get take homes. They did that obviously as a reason to have less people coming into the clinic. But what we have found is that it really increases client success, right? Like they get those sort of like rewards quicker, and then that increases the buy-in to treatment, and it's given the physicians and the nurse practitioners more autonomy, and that they get to define what stability is. And so what we have seen, oh, and also because of that emergency waiver and Medicaid rules, telehealth can now be used for intakes for buprenorphine products. They still have to have an in-person intake for methadone, right? Because the physical requirements look different, like the medical requirements look different for methadone than for buprenorphine. But that buprenorphine intake being over telehealth has really increased the amount of access to care for folks in the far west, right? That we have people that are driving 2 hours each way when they have to come in person to the clinic, because there just aren't enough clinics in the far west counties. And so being able to do that, we've seen higher engagement in treatment. And for folks that are engaged in treatment, we're seeing less overdoses, even though like we're seeing fentanyl on the rise, like David was talking about, in a huge way here in the West. We're still seeing less overdoses for folks that are in treatment, and less benzo use for folks that are in treatment. And we are unfortunately seeing more, like data from our local harm reduction organizations are seeing increase in overdoses for people that aren't in treatment, and increase in the comorbidity between opioid and benzo use. And then we're seeing in the perinatal community, unfortunately, we're seeing an increase in benzo use, especially for parents that are just sort of like stuck at home. I think anyone who has had a kiddo knows that that postpartum period can be really isolating in general. And then you put a pandemic on top of it, and now you don't feel safe having people come to your house and hold your baby while you take a shower, or, you know, just like offer that, you know, in-person support. Right. And so we've seen an increase in benzo use and alcohol use for that. And I think, you know, I think society-wise, there's been this big normalization of day drinking, you know, especially during the shelter-in-place orders. And so that has obviously not helped anyone that struggles with substance use disorders. And then also just in general, what I have noticed through my own private practice work is just an increase in trauma symptoms. Folks with a trauma history that have been stable for years are, you know, needing to increase their SSRIs or go back on meds or increase their access to therapy just because increase in trauma symptoms. And then we also have seen a lot of, you know, more IPV, increased substance use in general, increased child abuse that during the virtual schooling wasn't being caught as often. My supervisees at the OTPs have had to do a lot more Child Protective Services reports in the last year than they did previously, because kids were coming to the clinic with their parents because the parents didn't have any other option. And also because schools weren't able to catch whatever abuse was happening at home first. You know, so often my supervisees were having to be the ones to, you know, and luckily we're in that position, right, to be able to be the ones to make those reports to try to keep kiddos safe. And then I'll just wrap it up because I know we want time for questions, to talk about, really it's echoing what David was talking about of the provider experience, right? That the majority of what we talk about in group supervision these days is burnout and how to help my supervisees, you know, and then in my consult group that I participate in with other, you know, fully licensed people now that we're not required to do supervision is all about like how we're doing as people, right? And it's hard. I know personally I changed my entire schedule last year to be able to still see my clients and do virtual school with my kids. And I have a partner who is a frontline healthcare worker, so it was not an option for him to be home. And so we made it work, but it's been really hard, and I think all of us are struggling with pandemic fatigue.
Thank you, Marie. And I just wanted to point out at the Office of Rural Health, maternal health is something that's on our radar.
Mm-hmm.
Several of the inpatient labor and delivery units have closed over the past 5 years. A lot of them in the western part of North Carolina.
We have a huge OB desert out here.
Yeah. And I mentioned the health professional shortage areas on the mental health. Unfortunately, there is no maternal health shortage, or I should say there's no maternal health shortage measure. So there's no health professional shortage. They only have primary care, dental care, and mental health. But there's a severe shortage in nurse practitioners and not just the MDs or the OBs.
Mm-hmm.
And so our office is working to try to connect some of these patients and doctors through telehealth with some of the moms that are just missing their prenatal care. And then, as Kelly mentioned, they don't see their provider and they go to the hospital with a more severe case of pregnancy that's more complicated than it needed to be.
Absolutely.
I'll just add there's a comment in there from Dr. Smith, and this is directed towards David. I'll just read it for those that are on the phone. You're speaking of an issue that is concern and has been in existence for many years in our treatment model, approach and delivery, the continued rigidness of connecting funding and support services to only one approach must change. Additionally, updating loan forgiveness programs within behavioral health to the same level as physicians and nurses is needed to address the workforce. And at the Office of Rural Health, we do administer the federal and the state loan repayment program. And so that is for nurses, doctors, and there's a behavioral health subset. So there is some growing loan repayment dollars, but it does not match the physicians. The physicians get up to, I think, $50,000 loan repayment per year for 2 years. And I think the nurse practitioners get $30,000 for that. So the mental health providers are even lower than that. I don't know the number, but it's a start just by adding them and getting loan repayment programs for them because it incentivizes them to work in those communities. I think I don't see any questions there. Oh, I do see one. Marie and David, what do you think healthcare providers need from their employers to continue on this pandemic fatigue?
I mean, the first thing that comes to my mind is like the grace and flexibility to understand that we're all wearing multiple hats frequently at the same time, right? And so however that looks, the administrative director at the OTPs that I contract with is amazing at that. And so if one of her staff says like, I know I'm supposed to be in the office today because they're like rotating who's in the office when to do intakes, but I just can't, right? Like I don't have it in me today, or my kid needs something. She's really flexible and pretty amazing at saying, okay, then we're gonna pivot and I'm gonna call everyone else and see who can come in and cover those intakes today. And while they're still struggling, I think that has helped them struggle not as much compared to some other folks I know in other community health settings locally.
For me, I think if there were more effort towards employee incentives, and it doesn't necessarily have to be monetary, but something along the lines of just having more fun in activity. I mean, I like to refer to the story of Patch Adams and just being creative, innovative. There's several models out there that, in my opinion, represent a true workforce or work environment that does show appreciation. But again, it's not necessarily monetary. A word, a message goes a long way.
Great. Yeah, it sounds like between both of you, flexibility, but also appreciating your workforce and showing them that you care about them. So thank you both of you, as well as Kelly, for your information on this vital topic. Catherine Parker is going to close us out. She's from Hometown Strong. Catherine.
Thank you, Nick. Good morning, everyone. Thank you, Kelly, David, and Marie, for each of your presentations today. And most importantly, thank each of you, our attendees and partners, for sharing this moment with us. We could not have these sessions successful without your presence, and it is greatly appreciated. Let's see. So moving forward, we will have Spanish translation that is coming soon. So please keep an ear out for more information regarding that. We are planning to have Spanish interpretation for the next session, which will be September 15th. So once again, just please look forward to additional information about that ahead. Also, don't forget that there are resources, tools, and information that can be found on our landing page at foundationhli.org/NC Rural Coalition Fighting COVID-19. We hope you will join us on September 15th to hear about the NC Suicide Awareness Prevention Month. We will hear from Dr. Amelia Muse, Program Director of Center of Excellence with the Foundation for Health Leadership and Innovation, as well as we will learn more about the 988 program that will be launched in the weeks ahead. We will also have an update on the vaccination rates and the impact of the Delta variant in North Carolina. We would like to hear from you, as always. If you're interested in giving an update on your community's activities fighting COVID, please let us know. And once again, if you have any questions or need assistance, please feel free to reach out to Carla Opioil, and her email is carla.opioil@foundationhli.org. Once again, thank each of you for joining us today, and enjoy the rest of your day.